Harriette Van Spall, Associate Professor of Medicine from McMaster University in Canada, and I'm honored to have Professor Mamas Mamas from Keele University with me today, and we are going to discuss some of the late-breaking clinical trials at AHA 2019.
Well, thank you. It's been a real honor.
We are going to start off with ischemia, which has received a great deal of media coverage.
Yes.
Tell me your thoughts on the trial and on its implications to clinical care.
I mean, I think this is going to be a trial that we're going to still be talking about 5-10 years down the line. I mean, this is a very important question in patients with ischemia, moderate to severe, that may be symptomatic, may not be symptomatic. How best to manage them? Do we revascularize them? Do we manage them medically? Will it change practice? I think from the UK perspective, it certainly will do. I think now, in terms of patients that are symptomatic, certainly ischemia showed that there was a benefit from the quality of life perspective. So 50% of patients were angina-free at a year, only 20% with the medical management arm. No difference in hard clinical endpoints though, and certainly from the asymptomatic patients, again, no difference in quality of outcome measures, no difference in clinical endpoints. So yeah, I think it's really going to guide how we treat these patients. I mean, what's your feeling?
Well, I think it's important to remember the patients that were excluded from the trial. So
Yes.
anybody with severe symptoms, unstable angina, those with an LVEF less than 35% were excluded. And so the results of the trial don't apply to them. But I think there's great value in
Yes.
knowing when investigations will most likely be futile because they don't
Yes.
impact on clinical endpoints. I think there were some interesting sub-studies buried in there and secondary endpoints. Do you want to touch upon those?
Yes, I mean, the CKD sub-study I think was
Yeah.
very interesting. I mean, all of us expected, or many of us expected, that perhaps because of the higher event rate and the higher baseline risk of this population, that perhaps the primary endpoint would be different. And, you know, there was no statistical difference between the two intervention arms. So I think, to me, the study really asks the question, how do we investigate these patients? I mean, you know, patients had a coronary CT to exclude left main disease. And so now, you know, should we just be using coronary CT in all of these patients, or whether we should still be thinking about looking for ischemic substrates?
Right. I would tend to investigate those who have significant debilitating anginal symptoms because they might benefit
Yes.
from the intervention, and then optimize medical therapies
Yes.
in the vast majority of patients that we tend to investigate unnecessarily, perhaps. So another big trial that received coverage at AHA 2019 was DAPA-HF, and I'm going to talk a little bit about it. So the primary endpoints were presented at ESC.
Yes.
It was a groundbreaking trial that demonstrated that patients with heart failure and reduced ejection fraction who were symptomatic derived benefit from dapagliflozin regardless of whether or not they had diabetes. And some of the secondary endpoints were presented here
Yes.
at AHA 2019. Some of the points to remember are that patients derived benefit across the age spectrum,
Yes.
and this applies to elderly patients that are sometimes undertreated in clinical settings, regardless of whether they had diabetes or not.
Yes.
Patients derived benefit across the HbA1c spectrum. Importantly, non-diabetics did not experience hypoglycemia. Safety considerations often limit us from prescribing therapies in clinical
Yes.
settings, so I think these were important findings. Also, patients had improved health status with dapagliflozin compared to routine care, and that benefit in terms of health status applied to patients regardless of their baseline health-related health status. So these were important findings. Another
Yes.
one that's going to be presented today is how early after initiation of therapy patients derive benefit, and it's remarkably early. It's sort of within the 20 to 25 day range that patients start to derive benefit from dapagliflozin. So important findings that need to be translated to clinical care.
Yes, I think I was very excited by this study. I think it's really bringing to the forefront as cardiologists that we are having to get more and more experience with anti-diabetic therapies, There's a lot of discussion in the United Kingdom about who starts these medications, whether it should be the diabetologist, whether it should be the cardiovascular professionals looking after these patients. I think certainly, in my view, we're the ones that should be leading initiation of this, particularly given the impact on hard clinical endpoints. I think there was a lot of talk as well in the conference around inflammation, so colchicine.
Right. Why don't you tell us a little bit about the Coldcock trial?
So the Coldcock trial was very interesting. It was a randomized controlled trial of individuals post-myocardial infarction, and they were randomized to a low dose of colchicine versus placebo, and the primary endpoint was cardiovascular death, out of hospital arrest, stroke, or revascularization with anginal therapy. And it was quite interesting in that, first and foremost, patients tolerated colchicine rather well. I mean, often in clinical practice we see patients that don't tolerate it have gastrointestinal side effects. There was no difference in outcomes. In terms of the primary outcome, a 25% reduction in the primary outcome, mainly driven by revascularization for angina and stroke. And there was a lot of discussion around, what could the mechanism be for stroke, and I'm not quite sure why colchicine should reduce stroke. So I think, that's really
interesting findings, and brings to mind the mechanism of action of some of these drugs.
Yes.
So who would you offer colchicine to?
Well, I think, probably now most people after a myocardial infarction. I mean, there was clear exclusion criteria in this population. I think it's a drug that is readily available. I think it's a drug that's not going to have a health economic impact in terms of prescription costs. I think we have to remember that the outcomes were driven by a soft endpoint. So the main benefits seem to be angina, revascularization for angina. But I think there certainly is a lot of interest, and CANTOS again showed a reduction in cardiovascular events, but offset by increase in infections and fatal infections. So I think targeting inflammation without the infection hit is certainly of benefit.
Right. There were 2 heart failure trials that tackled some of the sex-specific outcomes that typically get underreported because females are typically underrepresented in trials. So one of them was my own.
Yes.
So the Patient-Centered Care Transitions in Heart Failure trial. And it was a stepped wedge cluster randomized trial in which we implemented transitional care services across 10 hospitals in Ontario in a publicly funded healthcare system. And we found that these interventions that typically are efficacious in mechanistic trials did not reduce the endpoint of 6-month composite all-cause death, readmission, or emergency department visit, but did have sex-specific treatment responses. So we found that males did not derive benefit from the intervention, but that females did. So females had a reduction in the 6-month composite endpoint, and the p-value for sex interaction was significant. So it gives us pause to consider. I mean, in the context of overall neutral findings, how do we apply the secondary outcome to men versus women in clinical settings?
I mean, it's very challenging. I mean, I guess it depends on whether you're a purist.
Right.
So from a purist perspective, this is purely hypothesis generating. I mean, one area that I thought was quite interesting is that you looked at all-cause hospitalization rather than heart failure hospitalization.
Right. Heart failure hospitalization and CV death are more sensitive to heart failure interventions, and they're typically used as primary outcomes in heart failure trials. We decided to be more comprehensive in our outcomes, and partly because to a patient, it doesn't matter whether they're in the hospital because of decompensated heart failure or from kidney injury. To them, the burden is as great. So we had patients provide input, and we also had decision makers provide input into the clinical outcomes that we chose. But we have done analysis, and we did not see a reduction in heart failure hospitalizations as well in the overall population. Now, we were underpowered for that. But just to give a hint that the findings are applicable to real-world populations in which it is harder to show effectiveness because you are including a wide spectrum of patients that are typically excluded from a clinical trial, and you're including those who are going to be non-adherent to therapy, those who have language barriers, who don't have a fixed address in which nurses can come and visit you at home. And these are real-world problems that we deal with, and so our trial reflects the effectiveness in an everyday clinical environment.
I mean, you've done a lot of work in the past looking at, interventions that can reduce hospitalisation in patients. So, I mean, what other effective interventions do you think that one can use in this population?
I think that the uptake of guideline-directed medical therapy, so those specific therapies that are evidence-informed and that have been shown to be efficacious, are what we need to focus more on. There's often inertia, hesitancy in implementing new drugs at the bedside. And we've seen this year there have been remarkable new therapies, and our paradigm of triple therapy now in heart failure with reduced ejection fraction has changed to quadruple therapy, and we still see some hesitation on the part of clinicians to initiate new therapies and to up-titrate therapies. So I think it's a matter of moving to what's been proven and making sure we afford these therapies to all of our patients as long as there's safety data to support it. And I'll end off with an interesting analysis in our pooled RCTs, so recently published and presented at AHA, were the patient specific analyses from the pooled trials of Paragon and Paradigm, and just to say that it affirmed that the benefit of ARNIs is derived primarily by those with reduced ejection fraction, and the treatment effect is attenuated as LVEF increases. There's also a sex effect, and so women are more likely to derive benefit at the higher range of mid-range ejection fraction and perhaps beyond. Men less so, but that the benefit of ARNI therapy doesn't extend to those with normal or high EF as we see in reduced EF. So these are important clinical findings that will impact care, I think. So thank you so much for coming and joining me and discussing.
No, it's a pleasure. I think these trials are going to cause a lot of vigorous discussions over the next few weeks and months, certainly.
I'm sure we'll be having some vigorous discussions ourselves, and I look forward to it.
Yes, look forward to it. Thank you.
Thank you.